Thank you so much for the very kind introduction. It never gets easier. Sorry, it's just always nervous, but it's a great turnout. I really am grateful to the organizers, the scientific committee for giving me this opportunity to be here to present to all of you. Yeah, and to all of you for being here today. And when I was asked to present on scaling up HIV prevention in Asia or Asia and the Pacific, I thought a lot about what scaling up means. And I think this is something that as a social scientist or implementation scientist, I like to be subversive, and also just really think about what that truly means at a very fundamental level, right? And I hope that comes across in the presentation today. And to do so, I'll be going through a few segments, just 3 segments. I hope I'm not going to exceed my time. I'll be wary of that. But I just wanted to share maybe what I see as the state of HIV prevention right now in the region. I wanted to use PrEP. HIV prevention is broad. I want to acknowledge that. We've got PrEP, we've got post-exposure prophylaxis, we've got treatment as prevention, but I think a lot of focus is on PrEP right now, and I'm going to use that as like a case exemplar on what are the issues on the ground that need to be addressed from a person-centered perspective. And I want to then end off with maybe some thoughts on how we can reimagine scaling up of HIV prevention in the region. So the first part, I won't go into too much detail because everyone here, knows it, you live it, you experience the gaps in HIV prevention, right? So, I would say that as a trend overall, we are seeing the new HIV acquisitions decline in the region over the years, but the decline is slowing and it's plateauing. You see on the left HIV incidents, on the right AIDS-related deaths. One thing to note is that while we see this very nice, smooth trajectory towards a plateau, it's not equity focused, right? The decline is not the same for all different countries. And in Asia and the Pacific, we account for 9 of the 32 countries around the world where new HIV infections have risen since 2010. Over here, you see some, familiar. We know, for example, in the Philippines as well. We hear the quote that there's been like a 500% increase in certain key populations as well. And this is not an even trajectory in the region. So equity is a big concern. We know, and this is just to illustrate that in the region also there's mostly key populations are affected, and I would add that young key populations are affected by this. So when we think about HIV prevention and this scaling it up, we have to reach those people, right? And I think one thing to also reiterate this point. I wouldn't be touching on too much of it today, but we also shouldn't forget that things like treatment as prevention is really important too. Because theoretically, if everyone got tested, got diagnosed, got access to care and on medication, actually we shouldn't see any new HIV infections at all, because of the science that we know today of the viral suppression and its linked to transmission. I found this paper this morning. I think this was published this year. And we've got some colleagues here who wrote that paper, but this was published as a paper in the Lancet HIV, which kind of drives home this point, right? That in Asia and Pacific, the region contributed 20.1% of all new HIV infections around the world in 2024. And however, 8 million users of out of 8 million users of PrEP worldwide, less than 5% live in Asia and Pacific. So you can see that access to PrEP and not just access, but maybe staying on PrEP is an issue. I'm aware, and many of the colleagues here, for example, Dr. Iskandar and team, from Malaysia, you also recently held very high-level meetings on, what we can do to address the implementation and scale-up of PrEP, including long-acting injectable PrEP in the region. There was also a community summit here in Bangkok, and many of us, are realizing that there is a lack of equity in terms of the scale-up of PrEP. And there are there's been consensus on what the next steps look like, which I won't go into too much detail. But these things are out there. Do take a read in terms of these publications. So the next bit is, I think thinking from the perspective of scale-up, what needs to be done? Innovations in prevention we have seen are necessary. these innovations will save lives, they will help prevent new infections or new acquisitions of HIV, but they're not sufficient, and we can see that in PrEP very acutely as well. I won't go into too much detail here, but you'll see over here that these are some of the key milestones, right? Actually, I was in Munich, but I wasn't at this session. So like I would like to, I would like to vicariously live through the electrifying environment through this photo, right? But I can imagine this was such a huge breakthrough, and many people got really excited about it. This year at IAS, I think there was quite a bit of talk, and I had the privilege of being the lead rapporteur for prevention science this year, and therefore I have been very made well aware of all the different updates in prevention science. And, the once a month oral pill to prevent HIV was also a big thing. And you can see here in the PrEP pipeline, we've got many different innovations for different types of people with different needs in the pipeline as well. And one thing that is also just a very sobering reminder is that in spite of all these innovations, and in contrast with the statistics that I shared earlier, it just is very clear that these innovations are not reaching people. And like as an implementation scientist, we focus on that, right? How do we get this innovation, the thing, to people, for it to be implemented, to be routinely used, to be practiced, and so on. And we can see that when we take an implementation science outlook, or kind of a perspective, over here you see a framework. It is a very popular framework in implementation science called the Consolidated Framework for Implementation Research. And if you see over here, the box in green is called the thing, or the innovation. And when we see the innovation, we can always think of like a pill or like a jab, I think this is where PrEP sits. And if we look at it from an implementation science perspective, it's so much more than just the pill or the injection. We have to go through the implementation process, like socializing people into how to use it, socializing systems into picking it up or normalizing it. We have to deal with the outer setting, we've got to deal with the inner setting, organizational characteristics, we've got to deal with politics, and so on. And beyond that, at the individual level, we also have to deal with a lot of things around, let's say, awareness, motivation, behavioral susceptibility, and so on. So these are some things that really articulate the complexity of how we can get these things to people and how to scale up prevention as well, right? At least from the perspective of, let's say, PrEP for now. But every year this is something that I share in all my implementation science teaching slides, right? This is a very famously and widely quoted statistic that on average it takes about 17 years for evidence to change practice. And every year, every new year, I don't reflect on this every new year myself. I think about other things, but every year that passes, I look at this sentence here, and it's become a self-fulfilling prophecy in some way, for PrEP. I look at this, and we get closer to that 17 years. And I was just wondering to myself, what needs to change, right? When we look at stuff like that. So I think we do have data around the region. I like to return to this big scale study on PrEP in the region called PrEP Appeal, led by colleagues at the Kirby Institute, at UNSW, and also, of course, with co-investigators from around the region, many of whom are here as well. And we think about, they have data on awareness, uptake, what are the reasons for not taking PrEP, even if you are aware of it and willing to. I think that's a good place to start, right, when we think about person-centered needs. What is the clear barrier or the most immediate barrier for people to take it up? Over here we see on the right a table that illustrates awareness of PrEP, or whether you heard of it. And the study did recruit transgender women, men who have sex with men. That was the focus of the study across Asia and the Pacific, and they disaggregated the data by income levels of the countries, right? And I think it's a nice way to also just look at investigate what are the different factors, right, that impact different contexts and different groups affected and at risk of HIV. Over here you see that awareness actually is, I guess, relatively lower among transgender women in general, and also in Asian low to middle income countries. There's much higher awareness in high income countries across Asia and also Australia. When you go down to PrEP use history and current dosing regimen, you would see that among those who are aware of PrEP, um, uh, we actually see about half of transgender women being current PrEP users. And I think the interesting part for me starts to come up where you see that in Asian high-income countries, there are just a little bit more people who have never taken PrEP before compared to Asian low to middle income countries. And when you look at current PrEP dosing regimen, you also start to see some interesting behavioral patterns and differences, right? For Asian low to middle income countries, there's a much more daily oral PrEP. Transgender women as well, in general. Unfortunately, they did not have, I guess, enough data to meaningfully disaggregate for transgender women. And also for Asian high-income countries, there's more event-driven oral PrEP. And I didn't show it here, but in a different table in the report, there's a higher awareness of event-driven oral PrEP in Asian high-income countries. And you can start to see here that maybe there's also like inequities in around awareness, right? For low to middle-income countries versus high-income countries as well. This is the part that also speaks to today, right? Like why scaling up is difficult. It's an issue because among those who have never taken PrEP, how many people are willing to take PrEP, or what's the proportion? Actually, a lot of people, like mostly, and this is quite clear across all groups here, that about 70% on average, will be willing to take PrEP. And this is the question, right? What are the barriers that prevent or leave that gap between that willingness and actually getting PrEP in hand? Okay, ignore that yellow box. I think I put it in the wrong slide. But this is an overview of the top few reasons, right, of the different groups over here. For transgender women, I'm worried about side effects. I don't know where to get it. PrEP is not available in my context. For men who have sex with men, in LMICs, I don't know where to get it. It's one of the highest. It's the highest. Worried about side effects. Also, it is too expensive. Actually, the interesting thing here for me, and also reflects the lived experiences in high-income countries also, is that it is too expensive is the number one reason for not being able to get PrEP in high-income countries. Don't know where to get it is another reason. And also, I'm not having too much sex. And from a behavioral science perspective, or as a social scientist, I think these are very interesting statements, right? Because I like to sort of unpack them, and I'm going to try and do that a little bit in the next segment here. With the goal of also just understanding, what needs to be done in terms of scaling up. So I don't know where or how to get it, or I'm not having much sex. I was thinking of a metaphor. I was thinking of an example. I don't know where or how to get it. When I think about this, what comes to your mind immediately? Okay, this is not a class, but I think I will answer myself. Sometimes it is maybe about you just go to the clinic, it's there, or this NGO, right? But if I ask the same question, how do I get from the airport to Eastin Grand Hotel? Or how do I get to the conference? People will ask me, what time are you going? Do you prefer a car or a train or the BTS? What's your budget? What time? Or what's the reason for it? So there are a lot of questions that come up that when I ask how to get from point A to point B, which reflect maybe an awareness of some of the considerations that need to be had, from a very person-centered perspective. But when it comes to PrEP, I also think that that's kind of reasonable questions to ask, right? When I say I don't know where or how to get it, the where or how needs to be questioned. The it also needs to be questioned. Are we talking about oral PrEP? Are we talking about long-acting injectable PrEP? Are we talking about event-driven PrEP? Do people even know what the it is? And that's the awareness part. And I think there's insight from behavioral sciences and a lot of studies from the community, right? That PrEP is a journey, right? And PrEP involves the uptake, the awareness, the use, the initiation, staying on it. The pause. It can be an intentional pause. It can be an unintentional pause. There are some different reasons for that, and there are different things that matter. I'll come to it later, but when we think of how we are measuring it in terms of PrEP persistence and pause, we are likely to think that stopping PrEP is a bad thing, right? But actually, for many people, stopping PrEP might be a good thing. Like maybe the circumstances have changed, but are we able to measure that and understand that in a deeper way? I think that's something to just put a pin on it first as I go through this. Also, like people change regimens over time. So this was presented at IAS in Rwanda this year, and one study tracked how people switched from oral to injectable, to being off PrEP, and there are variations in this across the journeys as well. So different it's great because the innovations themselves provide different options, right? But I think the stark reality is that also in many countries in this region, there are no options, or the options are limited, or there are barriers to accessing them. So when people are given these options, they are able to then take these as part of a toolkit of prevention, and then match that with their own needs as well. This is something that we do see in other sites. How about I'm worried about side effects, the other big barrier. I think one thing that I've been made aware of is, there have been so many studies in science, and every time you go to a conference, you'll be talking about, let's say, renal effects, like safety of certain kinds of medications. We talk about drug-drug interactions, and I think I reflect on that, and it's probably, if people don't even know that PrEP exists, which is reflected in the PrEP surveys, how are they going to know about such knowledge around drug-drug interactions as well, right? Or like safety profiles of PrEP. It's more complex, it's deeper, and it speaks to maybe the kind of work that we need to do in terms of public education and communications, right? Which if to be honest, if I look at my performance review, my university won't rate my performance on science communications as much as journal publishing, right? So I think some things probably need to change at a very systematic, or like a very high level in terms of also like grants, or like supporting communities that can actually fill that gap too. I'm just going to skip past these slides just for the sake of time, but we have so many studies. This is just the one from Singapore that ask people about PrEP. For transgender people, like there's also perceptions that it might harm one's body as well, right? Because of the hormone replacement therapy, other drug-drug interactions and all that. But we also start to see that there are many different studies out there that also kind of compare safety profiles for different types of PrEP. Different types of PrEP can be better for different people with different types of needs in terms of their biological needs. We also see that the studies here, looking at drug-drug interactions and whether it's safe to use PrEP, specifically for transgender women. And I think one thing that I'm reminded of is, if we don't engage communities and we don't ask them deeply about what their needs are, like these studies won't even happen. I think these studies, to me at least, speak to the needs of specific groups who are real and who actually need this information. So from this paper on, like we can then develop communication strategies that also help us, make sure that people are not just aware of PrEP. It's not good enough to be aware of PrEP. Have you ever heard of PrEP? It's not a good enough question, but do you know what it is and how can it be safe, and how to use it safely? And the depth of knowledge is something important to be worked on as well. And the last one, it being too expensive. I think this is a reality, right? Even for me, I share this often, and for me, like the reason why I got HIV myself was also because I couldn't afford post-exposure prophylaxis in my own country. And I think that as a young person, I reflect on that, and it also kind of shows in the data here that for high-income countries and low to middle-income countries, it is still expensive everywhere, regardless of how well-resourced the different countries are, because of different factors like licensing and also politics as well. And like in terms of PrEP, one thing that we were reminded of this year at IAS 2025 was that PEPFAR USAID initiated close to 4 million people on PrEP worldwide, and I think that's close to about half of PrEP initiations around the world. And you would know that if this funding were to be withdrawn, that leaves actually about half of the world's PrEP, those who have started on PrEP without PrEP. So I think that's something that's a very stark reminder of the situation that we are in today, that funding is going to be an issue. And I mean, it has always been, but it's going to be even harder time. And this was reflected in the panel yesterday that I had the privilege to be a part of. Yeah, so I mean, the yellow box was supposed to be here because it just highlighted the too expensive in the high income countries. But that's something that's a reality. Being expensive is one of the things that we probably have to work on. Like I think I'm also reminded that the pragmatic part of it is that a lot of times it's demand generation. It is communities advocating for things. It is making sure that governments and industry work together, to also do things like subsidies and all that. And that's something that at least in Singapore, I know we are trying all our different innovative ways of trying to get PrEP funded, because it is not subsidized in Singapore, right? And one bottle still costs maybe about 200 to 300 US dollars for brand name PrEP, right? So for oral PrEP. And like that's also not to say that we don't even have a long-acting injectable PrEP in our guidelines in Singapore. Like I think this is a snapshot of the guidelines, which says at the time of writing, LACAP has been approved for PrEP, blah 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 blah. It's not licensed for PrEP in Singapore. So I know that the process and the journey towards getting approval, is very different for different countries. Singapore, I believe Japan also just only recently approved like PrEP, for I think oral PrEP. Okay, please correct me if I'm wrong later. Come up to me and tell me that I'm spreading news. But I do know that a lot of high-income countries also, are a little bit slower. Because in that sense, with the lack of funding from a lot of international funders driving innovations, we are left to rely on our own governments to drive them. And with HIV, it's something that a lot of governments don't want to touch, including Singapore, or it's deprioritized. And I think that's left some of the high-income countries really behind in terms of advocating for access. Okay, so now I'm going to try and wrap this up in like 5 minutes because I do want some time for questions. What does scaling up even mean? And when I think about scaling up, the first thought that I have was, scaling up means that you have something that works and you want to scale it up. And we always think about scaling up as starting from the pill or the thing, right? I shared the CIFER framework earlier, but like the other thing that I think about is, why does scaling up not start from the needs of people? Like we always start from the thing all the way down, but like why can't we start from people themselves and think about scaling up as like scaling up access and the benefits of things in the context of this. So the starting point is not the pill, but the starting point is people, right? I think we've been doing that, but I want to sort of like reiterate and reinforce this point that is super important. And that's why I think we've always said communities should lead, should be part of the leadership in terms of the finding out what's the issue. And when that happens, we then have studies that address things like side effects. We then have science that address some of these different concerns as well. Like for example, I think one big thing at IAS this year was also including pregnant people as part of clinical trials. Like these are all things and innovations that change systems, but are also things that are demanded from communities themselves. And one thing that I wanted to propose is that when we do things from a person-centered perspective, and when we start to think through things, then we can sort of shape the science and we can shape how things are measured, how we fund things, and how we collaborate. And I think it made me think, what does a person-centered, demedicalized prevention paradigm look like? I think of redefining health, redefining care delivery, and redefining success. And this is some ideas that I got from listening to some of the talks yesterday as well. For example, when it comes to, let's say, aging, there was a huge focus on, just not looking at the biomedical aspect, but the social aspects as well, right? And when we think about HIV acquisition, you can think about things like sexual behavior, transmission pathways, and how HIV prevention, a lack of access to information is a very big part of that. This is a part that, the stuff that you see here now is really, speaks to what I've been speaking to, right, in terms of access and also information and prevention. But if we redefine health in this way, if we focus on this, it does a disservice to people, right? Because we see that the science has also shown that things like sexual behavior, things like access, they're all part of a bigger syndemic, right, of different things around psychological health, around substance use, around policy, stigma and discrimination, and so on, right? So, how health is defined, helps us shift our lens away from just measuring if people are taking up prevention, but, measuring if these important determinants and fundamental causes of health are also addressed in the ways that we do prevention work. We also see that there's redefining care delivery. There are many ways to demedicalize PrEP in many ways to shift it away from health systems that hold a lot of power and dictate a lot of different pathways for people, whether it's because of policies and so on. But there's also guidance from the WHO, right? To say that a lot of these things can be decentralized, and like you don't have to actually wait for a definitive like kidney function test first before you actually start someone on PrEP. You can use a rapid testing, you can use like these kinds of self-testing modalities to initiate PrEP, but eventually get people on the test that they need, right? I think that's something that I don't actually see happening a lot. And in places like, for example, like Tangerine Clinic, right? You see what I've been talking about in terms of redefining health, making it more people-centered, making it more demedicalized and decentralized. Things are happening here. In IAS, also one big thing that was shared was how we can bring services closer to the communities. Big data can identify so-called like hotspots. We can engage communities to bring PrEP and prevention services to like bars, to clubs. I do know, like for example, in the UK, like pop-ups in bars, to give like mpox vaccine, PrEP, things like that. Actually bring things closer to people, potentially. And lastly, redefining success. Like for example, when you think about PrEP, I talked about measuring PrEP persistence earlier, but that's something that I've been trying to change and been trying to promote. That like just measuring persistence is not. It feels very disjointed from what people need. And I think people have been writing about that. This was a paper from like 2015. People have been publishing about that, which says that the PrEP persistence paradigm is a clinical trial philosophy. And now that we are moving towards implementation, moving it towards people and behaviors, to move it to a person-centered philosophy is to measure not adherence, but also prevention effective adherence. What that means is that people are, on PrEP at the times that they need it and they want it. Right, that is actually during the times where they have actually risk events. So it gives more nuance, it gives more resolution. It actually ties better to what people need at different points in time, and so that like if we see people not being on PrEP or not adhering, in itself we cannot make any calls to say whether we're succeeding or not. But when we take it from a person-centered perspective, we can then see like whether it works and whether they have access. Okay, this is my last slide. Sorry, I only have 2.5 minutes left for questions, but like just to reflect, scaling up, starting from the pill, but should we just work on tailoring more, like starting from people, and that would shape, I think it's an opportune moment also, like to redefine success, to redefine grants, to redefine funding. How are we going to do that makes things more people-centered and empowers communities to be leading a lot of these things? But yeah, thank you so much.